So, it's my pleasure and honor to have you here, Fulvio.
Thank you very much.
From London, a real gentleman from London. And I know all your talks are very impressive at the show, and I'm really looking forward to this one.
Thank you so much. I can't tell you what a privilege it is to be here on this stage with this faculty. My goodness. I'm talking about high-volume fat graft breast augmentation. We've skipped lunch, it's late, it's hot, so I'm going to try and keep you awake by talking about something a little bit different. Now, if you talk to plastic surgeons and say, do you use fat graft? 100% they'll say yes. They've done it, you know how to do it, everyone does it. Right. If you have a lady come to you for 300cc breast implants, will you talk to her about fat as her sole option? And most will not, so I'm going to explore what those barriers are. I'll talk a bit about how my technique evolved and how I think I started off like most people, and my results have got better, and I hope to share that. And then talk about, does it work in the long term, and when should I think you use it, and when shouldn't you? So, my name's Fulvio Urso-Baiarda. I practice outside London in a place called Berkshire. Start with a hook, they say. This is my hook. So this lady came to me, 36-year-old woman, quite typical. She goes to the gym, she works out quite a lot. Wasn't really seeing the results that she wanted globally, but she was fit and athletic. I think it was 4 times a week, which is 4 times a week more than me. Bit of breast asymmetry, incredibly scar reverse, and she walked in saying, as I'm finding a lot of people saying, I do not want implants. I absolutely refuse implants. Most of them won't end up in your office because they don't think you're going to give them anything else. But when they start to know that you do, they will find you, believe me. Now, she had these limitations, but in other ways, she was pretty compliant. When I said to her, have you thought about fat? Could I use your fat? And she said, yeah, sure. Do I go from your tummy or your thighs? And she said, both. I distinguished between liposuction for fat grafting and body contouring. I said, if I'm liposuctioning, would you mind if I sculpt and use some of these high-def techniques as well? And she said, hell no, you can do that. I didn't know that was a thing. I said, you'll need tightening as well. She said, yep, do it. And I couldn't ignore the asymmetry that she had between those breasts as well. And I said, look, would you accept at least one areola scar? So she said, sure, if you need to. And when a lady like that says yes every time I ask a question, this is the kind of result you get. And we grafted at one stage 415 cc's per breast. And I emailed her yesterday. I wanted to copy an email that we sent our presentations in ahead, and said, how are you doing? It's a year on. She said, I've lost nothing. It's all there. And I said, this will drive your body contouring practice, because a lot of, in the UK, it's not such a well-known thing, at least. And I have to point out that it's not just normal liposuction. So I sort of show markings and I say, okay, these shadows don't just happen by accident. You have to plan them, they're intentional, you have to design them, and you have to use these techniques. And by doing that, and they see these shadows and they like them, and they say, okay, I want this, whatever that was, that's what I want. Now, I was at a breast implant conference a few weeks ago, their summit. 8,500 women worldwide were surveyed, and almost half of them were unsatisfied that their breasts were not large enough. Almost half, a huge sample. And how many undergo breast augmentation with implants? 0.14%. I was blown away. In the USA, where breast implants are probably less stigmatized than in many other places, more heavily marketed, that figure is 0.17%. So is it not abundantly clear that we are not giving women what they want? They want larger breasts and they don't want it with implants. And you look into why that may be, and external judgment, looking fake, turning up to the school run as that woman with the fake breasts, real concerns about device failures. Every few years another device publicly, spectacularly crashes with issues. Where's the scar going to be? Is it going to be visible? And implant manufacturers are rushing to fill that gap and create ever more minimal scar techniques. But for me, here is the elephant in the room. Why are we arguing about whether it's going to be a 3.5 or a 4.5 centimetre scar, and whether it's going to be in the crease or in the armpit, when, you know, a 3mm scar that you can barely see, a single 3mm scar on each side. So I asked surgeons, do you offer lipofilling to patients presenting for primary or secondary breast enhancement. And most never do, or sometimes do. The huge majority, that's about 70% of respondents. So I said, okay, well, why is that? Why don't you do it? The majority think it's not possible to get enough volume. The next most popular response is that it just doesn't last. And then people think it's cost prohibitive and you can't get the kind of look that patients are wanting. So I say, okay, on that point of volume, how much do you tell patients you can get in? What do you think is possible? Most say up to 200 mils. Now, when I consult with a patient, if I genuinely feel I'm going to get 200 mils or less, they're ruled out. I will not offer fat grafting. I'm more typically looking at this kind of volume. In the UK, most women are asking for less than that, and the graph on the right is showing sales, global sales of breast implants from one manufacturer in the last year. And it's showing that more than 500 cc's are well out of style, 400 to 500 and 300 to 400 are also dropping over the last few years, and the growth is being driven in that 200 to 300 cc range, which really neatly overlaps with what we can achieve with a 3mm scar through fat grafting whilst improving the rest of the body too and harmonizing the rest of the body elsewhere. Now, when I'm talking to other groups of plastic surgeons, this is a big barrier because they've got to know how to take large volumes of fat. They've got to be able to tighten the tissues afterwards. They've got to be able to contour. You guys, everyone here has all of this right now. You're getting to 30 minutes before the end of the operation and throwing away the fat. So okay, how is this possible? I said that this is a viable alternative. I want to show you this lady. She came to me in clinic and she said, I hate my breast implants. They look like a builder's bum. And I said, I'm just curious, what do breast implants like a builder's bum look like? And then she showed me, and she's right, they do look a little bit like a sort of builder's bum cleavage if you're doing the plumbing, and she's, you know, looked a bit like that. I got it. Now, this is where I was at. I was grafting a lot, I was getting horrendous bruising, it looked awful. And I call that a dinner plate deformity, because it looked like someone's taken a little saucer that should go under your coffee and shoved it into a breast. Radial expansion, a lot of flattening, didn't like it at all. But, thankfully, it settles down. And I thought I was doing well with 250, by the way. 250 was really pushing it in those days. And then after a month, it softens, and after a year, it softens again. And it was fine, she was very happy. But I did see her that first week thinking, I really hope this settles down, because I was pushing my volumes at that point. Here's the problem. So, we all know this general schema, doesn't apply in the limbs, but we've got deep fascia on muscle, superficial fascia separating two planes of fat. And it's the same in the breast, except the deep fascia wraps around the breast. And when you graft, as I think most of us start doing, reasonably superficially, it stiffens that top layer. It prevents projection, and it prevents you seeing what you're doing underneath. And we fill it, and it's turgid, and we stop. There's all these planes underneath that we have kind of missed out on our opportunity for, and that's it, the case is done. So I moved on to just paying a bit more attention to grafting a bit more deeply first, and just doing that superficial stuff at the very last. And lo and behold, nice filled results, still expanding, still projecting, not getting the horrendous bruising. I did this with an abdominoplasty, and then, again, this was very many years ago. What do I do, step by step? I'm going to rush through this a bit more quickly than I otherwise would, but I love ultrasonic preparation. I use a 3.7mm 3-ring cannula pretty much all the time. I keep the power at about 70%, and you get this lovely fat, and that just looks beautiful. And the reason I think this helps is you get this little pate of fat with a huge surface area. Before I used to do this, I'd get globs, and you're expecting these to smear and spread around the tissues. But with this pate, it does most of the work for you. It doesn't block your cannula. You can graft without swearing and getting frustrated. So the case I'm going to show you is a secondary case. Post-explant, you'll see how flat she ends up there with the implants out. And I do this exact same thing through a 2 or 3mm incision, but this is great for filming. But you can, once you've done a few of these, you can feel every plane. And you can see, at first you go under the muscle, you can get 80 to 100 mils in that plane really easily. And as long as you confine your, people are worried about blood supply. It's a type 5 muscle, as we know, and those are the two vascular supplies. As long as you confine yourself to the footprint of the breast, as if you were doing a breast augmentation, you're safe. You're away from the thoracoacromial and the perforators. Then intramuscular, there's not quite as little resistance there, but there's very low resistance. And if she's got a good muscle, you can get a second plane into the pec as well, superficially intramuscular. And you can be hitting 200 cc's before you've left the muscle, quite easily, 250. In a case like this, where there's an implant before and you don't need to remove the capsule, you often do, but if you don't have to remove the capsule, you then got a subcapsular plane. And it behaves quite differently in the subcapsular plane. You can't get quite the same volume, but you see it smear and spread. A whole new vascular plane. Use every plane. When I'm doing a wise pattern explant, but I'll often auto-augment. And you can graft the auto-augmentation as well. I'll graft that too. Especially if you're joining median and lateral pillars, you need to, because you can't graft over the join. So if you make up for it by grafting the auto-augmentation, you're good. You can get away with that. I hope you can see, step by step, how much volume we're gradually getting. Now, plane 6, and now I start on the parenchyma. And you can often go 2 planes on the parenchyma. That has no implant in it. I mean, it looks pretty much like the other side in terms of volume. No implant in there at all. And the last little trick I like to do is it's nothing to do with volumizing the breast, but by liposuction the axilla, you get a nice side boob, and you can just accentuate it, define it. It's just a nice aesthetic touch. And I've said, look, you've got the skill set already. It's all waiting for you. It's on a plate. You can do this. So objections. It doesn't last, but it does last. And I'll show anyone this email this lady sent me yesterday. But I've been thinking for a long time, wouldn't it be great if I had a lady come to me who needed fat grafting to one breast and a totally different breast operation to the other breast? That's going to give us the answer. And then this lovely lady walks in. She'd had breast cancer, she had a breast reconstruction done, and she had a reduction on the other side. This was all on the NHS, but she was still too big on one side. So I said I would re-reduce her reduced side and I would graft her other side. So she's having fat grafting to one, a different breast operation to the other. They always look a bit funny early, and this was the 2-week result. I grafted 420 at a single stage, and there we have her after 4 months. Both sides have reduced, to my mind, by a similar amount. You get 90% of your reduction in the first month, and the last bit by 3 months, and then it's stable. And then they'll gain weight. If they were going to gain weight, I have patients having this at Christmas, and they come back to me in January and they say, I gained a cup size over Christmas. It's a really nice operation. They love that, by the way. Needs multiple stages. Well, I've been doing this now for 7 or 8 years, and I've had 3 or 4 have opt for a further stage because they wanted more volume. So this is going to be one of them. But it's very elective. They're not disgruntled, they're not unhappy. And when they do it, it's interesting. The mindset is, well, if I'd had implants, I would have needed another implant operation in 12 years' time. So I'm just going to bring that forward, and I'm going to use that budget for this. So she actually came to me for her tummy, but she heard about this fat stuff I like to do. And so I did an abdominoplasty, and I grafted her. And I could only graft at that stage 240 and 200. She had this flap of skin, no recipient site. But then she came back a while later, about 6 months later, and she said, turns out I love breasts. I never knew I loved breasts, but I love breasts. I love my breasts. I'm obsessed with them. I just like more of them. So we did the same again. 460 per breast at the second stage. She's had 700 cc's grafted. Very hard to make fat grafted breasts look odd. If I put 700 cc implants in this lady with a mastopexy, that would have been freaky. That would have looked weird. But she's got a result that she really likes, that she's really happy with. Okay, so it's not right for everyone. Difficult cases. It could be either the recipient site or the donor site that lets you down. In this case, she's got a great donor site. She's got big thighs, big calves actually, lipedema. But she had small breasts, and I couldn't get that much into a breast in one stage. It's got to be surrounded by healthy tissue. It's a graft. So I was able to get 250 cc's in. She wants another stage. I'll probably get 350 to 400 in at the second stage. So that is a result that she was really happy with. That was plenty for her. I was kind of hoping she might come back. Ironically, so this lady had neither donor site nor recipient site, BMI of 17. She was sent to me by a local plastic surgeon who was saying, well, I don't want to put breast implants in her. She's too high risk for breast implants. Why don't you fat graft her instead? To go and see my colleague. And we looked at each other over the table and said, what, is this guy for real? Where am I going to get the fat from? And she said, right. So I put breast implants in. And that was fine. That was as natural a result in a dual plane, believe it or not, and a very slim patient with their ergonomics, actually. So the majority of patients who come to me, I find, are suitable for this. So the indications, well, my favorite indication is just a primary breast augmentation. And I do exactly, if the patient opts for it, they've got a very structured pricing system, but I like to contour them, I like to define these areas, and you can see on that bottom right picture that as well as a nicer tummy, she's got this lovely breast contour. That was $350 per breast, single stage. Her brief to me was just, I don't want to be particularly big, I don't want to be huge, I just want my breasts to walk into the room first. That's it. And so we've got that brief. And so primary augmentation, in this case with a periareolar mastopexy, and I'll do that quite often. Another example, this one was in 2 stages. And it's very elective, it's not acrimonious, it's not a revision. You tell them what you can achieve, and some of them will opt to come back for a second stage, and it's absolutely fine. She's really happy. And she's never going to have to worry about an implant risk, and she tells her friends, and they talk about it, and it markets itself. One thing that I do like about fat grafting is its versatility. We all have patients with asymmetry, and are you going to use a 280 and a 330, or what are you doing? And you're using 3D imaging, and it's not quite right. Sit the patient upright, and you can say, okay, medially they need a little bit more on the right, I'm actually going to take a bit more laterally on that, and you can really, really symmetrize an asymmetric patient very nicely. Secondary cases, I get a lot of implant dissatisfied patients as well now, and this lady had obviously a waterfall deformity. I hadn't put her breast implants in. She could have done with something of a mastopexy and didn't have it. She was this slim, willowy lady, and yet had a lot of fat excess in her tummy. She put it all in her tummy, and she wanted to be smaller. And the elephant in the room was, why don't we just take it all from your tummy and put it into your breasts? She told me that she was an A, maybe B cup before her breast implants were put in, so we knew we didn't have a lot to work with. But that's just a much more natural result, and it's total body harmonization. You're looking at the whole patient. You cannot be tunnel visioned when you're doing this. You have to examine the entire patient. And you don't get the sort of weird, freaky, late breast implant outcomes with this. This will age with the patient. It will age gracefully if she develops ptosis. It will tose, but it won't look weird. I sometimes get patients like this. Now, I prefer to graft at the time of explant, but sometimes they'll have gone elsewhere, they'll have been explanted with a capsulectomy in this case, and then just realise they just can't live with this and become quite psychologically kind of broken, and then come to you. And I told this lady that she would need 2 stages, and you can see the distance between her breast crease, the scar of the crease, and I said, I'm not going to be able to push with fat graft. I'm not going to be able to expand your breast base to that extent in 1 stage. I don't think it's possible. And she said, well, I can't afford 2 stages. Doesn't change my advice. You need 2 stages, but I get it, but it's setting expectations. Okay, so she's only had 1 stage, and I will accept it's not a perfect result. I would have loved to have expanded out that left breast in the inframedial bit. I'd love to expand out that lower pole a little bit more, but she's really happy with that. She can wear clothes, she can look okay in swimwear and underwear. She's okay with that, and I'm kind of, again, she's one that I'm hoping will come back one day, but she's happy. Patients generally love this, and it's not that infrequent we get lovely messages like this. And it's something that I feel you should offer. Look, if you start talking about it routinely, not everyone will choose it. and not everyone is suitable for it, but most people are suitable. And when you offer it, when you start offering it, you're not going to consign absolutely every patient to breast implants, whether they needed it or not. It's just about choice. And as renuvion surgeons, you are better placed than most to start doing this. It's a really short learning curve for adding this to your repertoire. So I commend it to you. I thank you. This is the hospital that I'm based at in Berkshire. I had some friends open this 2 years ago. It's got 5 operating theatres, 3 main ones, and inpatient rooms, and I'm very proud of it. We love it. I'd love to welcome any of you to that anytime you would like. And we do sometimes do these little courses. These come up now and again. So you'd be welcome to come to that, but you're welcome to come outside of that as well. So please get in touch if you're interested. Thank you.